We will proceed further with the next speaker today.
Okay.
So it's my great pleasure to present Dr. Wu Pan Hung, who is from Singapore, who's going to be talking to us today about transforaminal lumbar spine surgery. Please, Dr. Wu.
Yeah, I'm around. I'm overseas, so I asked Ahmed to help me play out the video, and then in case the internet reception is not so good.
That's great. Okay.
Yes, please go ahead. Thanks, everyone. I'm Dr. Pan Hung Wu from Ng Teng Fong General Hospital. Today, I will be sharing how I do it, transforaminal endoscopic lumbar spine surgery. I would like to thank WFNS for giving me this opportunity to share my experience in transforaminal endoscopic lumbar spine surgery. It's my acknowledgement and conflict of interest. I would like to thank my fellow Dr. Rohit Kavishwar, who have contributed significantly to this talk. The aim of endoscopic surgery is to provide a safe and targeted access to decompress pathology with minimal soft tissue trauma. There's few advantages in endoscopy: a magnified visualization, a good working channel that have customized endoscopic instruments that can bypass the soft tissues to minimize repetitive trauma to the soft tissue to the operative field directly. We have a constant inflow and outflow irrigation system to eliminate bone dust, to provide a clear visualization, and to wash away debris. This is an example of a patient who have underwent transforaminal endoscopic lumbar discectomy, TELD, and you can see that he underwent an LA sedation, 30 minutes procedure, and post discectomy, the MRI shows a resolution of the disc. And this is a patient who had underwent a lumbar 1-2 TELD, and you can see that the patient can ambulate and go back to work in a very short period of time, and in the 1 year follow-up, pretty much back to normal. Previously, he was very disabled and was wheelchair bound. In the nomenclature, transforaminal surgery focuses on mainly transforaminal endoscopic lumbar discectomy, extraforaminal endoscopic lumbar discectomy, as well as lateral recess decompression and foraminoplasty. Transforaminal endoscopic transcambin fusion is an extension of transforaminal surgery. And you can see from this diagram, the transforaminal procedure are mainly located at a distance from the midline. Essentially, in this algorithm that was published recently in Spine Journal, they suggested that transforaminal surgery will be beneficial in the upper lumbar region for all zones for discectomy. In the lower lumbar region, because of the high iliac crest or a high grade, especially upward migration, so for extraforaminal and foraminal lesion in L5S1, transforaminal is a good choice. The types of transforaminal surgery essentially very much depending on the approach angle. If you're doing a discectomy, then 30 to 40 degree angle for the central and paracentral region will be adequate. For extraforaminal, perhaps a steeper angle of 60 degree will be useful. And transforaminal, foraminoplasty and fusion of 40 to 60 degree angle will be sufficient for the discectomy and fusion, the foraminoplasty. In my mind, if you are starting transforaminal surgery, we should probably start in the L3-4 and L4-5 central and paracentral disc. Then we expand to foraminal and extraforaminal disc and other expanded indications. There's some relative contraindications of TELD. Existing nerve root abnormalities such as duplicate nerve root, low-lying nerve roots, high iliac crest, especially in upward migrated disc, may find it a challenge to actually reach the paracentral and the central region of the disc. Pathology related, if it's a very calcified disc or extensive central and lateral recess stenosis, may actually have implications for beginners in TLD. In terms of equipment, we need endoscope, a fluid pump for continuous irrigation. The irrigation pressure I recommend around 25 to 70, mostly at the 25 to 45 mmHg region. The video endoscopy tower will require video outputs and we require recording system. We need a working cannula of various types, which I will show you, needles, obturator, kerosene ronger, forceps, pituitary punch, pen field dissector. We need very good radio frequency ablator, drill or reamers. There's some additional devices that can be useful, such as suction irrigation shavers, side-firing lasers, atrophying or shaver. So a typical dimension, inner diameter 3.7 to 4.3 millimeter, depending on the size of the task that you are looking at. A bigger inner channel, working channel always can always give more powerful equipment. However, too big outer diameter may cause some discomfort to the patient. So we will titrate accordingly, and you choose the endoscope of your choice. In terms of working length, there are, if more obese patient, we can use a longer working length. Generally, 170 to 180 is adequate to reach most of the patients in the central region of the disc. As you can see from the various type of working retractors, I typically use the type B, which is the bevel tip, which allows a visualization of both the nerve root and allow a good passing of equipment. The bevel part can protect the traversing nerve roots, while we effectively can perform discectomy. The type A will be useful for extraforaminal disc, so that we can actually access directly to the disc and protecting nerve root. There's some advantages of radio frequency ablation, and using the correct radio frequency ablation of short bursts can perform hemostasis. There are currently new probes that can actually bend more than 90 degrees, designed by, for example, Bones. We call it Cannon Spiral Probe, recently launched, and it can be bent more than 90 degrees to assess difficult places. Foraminoplasty is an essential part of the surgery. It can be done fluoroscopically or endoscopically. In the inside-out technique, which is popularized by Dr. Anthony Young, is essentially we insert the working cannula directly into intradiscal space, and then working channel subsequently, and perform discectomy from the disc, and then we pull out to perform the foraminoplasty. While that is a very effective system in doing discectomy, there are some limitations. You may have potential to cause exiting nerve root dysesthesia, especially in patients who have very tight foramen. So Dr. Thomas Hoagland subsequently suggested we should do a fluoroscopic guided foraminoplasty, and he designed the Maximal system with the side rimmer system, which is safe for the existing exiting nerve root. There are also front rimmers by various company that can help in foraminoplasty. Professor Hyo Sung Kim have suggested that we should use a mobile outside-in technique, which I essentially call it an endoscopic visualized foraminoplasty, which I have employed in my practice. So you can see a front rimmer. The front rimmer advantage is that you can cut the bone facet joint in the front, but there is a potential of injuring the traversing nerve root if we are going too medial, meaning more than medial pedicle line for L4-5 and L3-4, and perhaps mid pedicle line for thoracic and lumbar region. So in Maximal, they also have the side rimmer, which can do foraminoplasty without actually potentially rimming the traversing nerve root. In terms of endoscopic drill, we have to choose a good endoscopic drill with a slim handle, good pedal. So why we use slim handle is because we want to have less vortex effect. Vortex is commonly associated with rotating motion, and the fluid around the rotating motion can lead to a vortex that you can see from here. A smaller rotation, slimmer handle or holder can lead to a smaller vortex. Additionally, you can see that a slim handle, such as this NSK drill, can visualize very well what is happening around the foramen. Or a large, this same transforaminal surgery, a large handle by another company can lead to quite obstruction of visualization. Although we can circumvent by keep turning the endoscope, but it may not be so effective. So essentially, we need to do pre-op planning. We need to find where's the disc. We have to analyze the size of the patient. We want to find out where is the lumbar segment, upper lumbar segment. We have to acknowledge the kidney and the traversing nerve root relationship with pedicle. As we go up in the upper lumbar segment, the traversing nerve root get closer and closer to the pedicle. And then the foraminal size, if it is a very small foramen, then we may have to do a trans-SAP approach where we doctor the SAP and do a foraminoplasty or endoscopic foraminoplasty before we enter the foramen to prevent exiting nerve root injury. And if there's a high iliac crest, maybe we have to consider interlaminar, or we do a special techniques, which will be out of the scope of today's talk. You have to build a safe corridor, and the safe corridor is famously proposed by Kambin and Hijikata, and it essentially involves the triangle that subtends by exiting nerve root, traversing nerve root, and the top of the caudal vertebral end plate. Essentially, we want to be docked in this posterolateral corner region so that we minimize the injury to exiting nerve root or that of the vessels or vascular vessels around the structure in the vertebral body. If we place it too anteriorly, we may injure the exiting nerve root. We place it too posteriorly, it doesn't reach the target. So the ideal will be the lower dorsal region of the Campin's triangle. And the trajectory is important. If you are too shallow, then you'll be getting into the sinus. Too steep, then you'll be getting into the retroperitoneal region. So a good angle of 30 degrees will be adequate. So what angle do we use to assess to the different discs? You can use the average distance or use the MRI measurement to reach the ventral epidural space. In terms of the distance-based approach, Campin and Gelman suggested entry point to be located about 8 to 12 cm away from the midline at about 35 to 45 degree angle. And generally, we accept about 30 to 45 degree angle. Dr. Rutan has suggested in the lower lumbar region that we can consider using a very direct lateral or modified lateral approach, extreme lateral. And we can do it in the patient in a lateral position so that we can have a direct access. Personally, I do not use this approach. You can see from this paper by Dr. Lee, you can see that if he did the analysis at 12 cm and see how much retroperitoneal violation. And at 12 cm, actually, L23 is 75% retroperitoneal violation and major the kidney. And L34 is also not too infrequent, it's about 7.1%, which is quite significant. And then maybe an L45 and L5S1. I think at 12 cm is acceptable with very minimal retroperitoneal violations. Dr. Rutan also recommend not to do at L1 to L23 level. And generally, if at 10 cm from midline, L23 is safe. In terms of lateral view, we can aim our needle to be around the region between the spinous process and the lamina. In our paper, we also suggested that when we ream or when we dock, we try not to dock beyond the medial pedicle line for upper lumbar level, because then the presence of the kidney and the dura expansion together may make it a higher risk of injuring neighboring structure. Overall, we can palpate the lateral edge of the paraspinal muscle, so we try to just be at the edge between the soft and firm part of the paraspinal muscles. Personally, I can calculate it by trigonometry. I use the tangent of the angle. And you can see that if you calculate the tangent, we always know the midline, the disc distance to the skin, which is the opposite part of the tangent equation. We want to know the adjacent sides because that's where the distance that we want to be to get into the disc. So from using tangent, if we calculate the angle to approach the disc is 30, tangent 30 will be the adjacent side distance where we want the needle to be will be opposite side divided by the tangent 30, and then we get that distance that we needed. It requires pre-op planning. This is how we position and how the anesthetists and our X-ray technicians are situated in our nurses. Generally, we prepare the patients in a Wilson frame, radiolucent cable, and for L45, we can position them flat in this way, and we can mark the entry point. This is a video showing how whether the L45 will be parallel to ground X-ray. Okay, hold on. As you can see from the video that the monitor that the L45 is parallel to ground X-ray. Okay, and then you know that this is probably the lower plate of the L5, upper end of L5, and then the lower part of the Campin's triangle. Okay, then we do AP view. A lot of the markings depends on the AP view. Pre-operatively, I've calculated based on trigonometry that we need about 12 cm from midline, 12.5 cm from midline to be exact, to get a 60-degree approach angle this surgery. X-ray, so we'll mark the midline. It's very important to get the exact midline. X-ray again. Okay. Sorry, making this drawing on your back, okay? So we mark the lower end plate now, X-ray. Can you go more south? More south. Okay, stop there. Go through a little bit. Okay, stop there. Okay, right there. Okay. X-ray. Mark the lower end plate. Then mark the upper end plate. X-ray. X-ray again. Okay, next. measuring about 12 of the yeah, sure. So about 12.5 cm of the line, that's calculated based on trigonometry about here. And as you know from our L45 doesn't have a kidney, so 12 cm of the line should be fine. That's the area, that's the length of the position needed. So usually I go from the touch double and play and aim for the mid pentacle of L5 actually. So about there, and then it is here. On the lateral view, we will see. Lateral view, so 12.5 cm of the line touches the upper end plate and touches the mid pentacle of L5. Okay? So then from here we know about we'll be starting from here and in that way. X-ray. Oh, sorry, she is breathing easily. X-ray. Hold your breath, sir. X-ray. Perfect, right? So this is where exactly we will be like during the surgery. You can see the triangle. This cross is right at the entry of the skin and will be perfect on the Campbell's triangle. So overall, we use a three-step maneuver in inserting the needle. We palpate the SAP, and then we push ventrally into the disc. When we are at the SAP, we inject local anesthesia, and then we push ventrally and enter the disc safely to the medial pedicle line. So this is a video showing how we did it, and then we make an incision on the skin, and then we put the needle. This is a right-sided approach. We now feel the superior reticular process, then we go ventrally and do X-ray. We palpate the superior reticular process this way, and then when we feel the bones in the AP lateral view, then we can actually, according to the AP lateral view, adjust the needle, usually meaning we will pull back slightly and then move ventrally into the medial pedicle line, this space, and then we can inject the needle kami with contrast. That is an optional step. You can also just put in the guide wire and then subsequently perform fluoroscopic rimming, or directly put in the dilator and the working cannula and perform endoscopic rimming for the endoscopy, mobile outside-in technique. This is a very mobile technique. As we enter and do a foraminoplasty, we drop our hand so they get a more horizontal trajectory into the central region of the disc. So overall, facet is a door, the pedicle is the pivot of the seesaw, as you can see, and we can use that pedicle to lever up and down to get into a suprapedicular root, a foraminal root, or intervertebral root to get into the disc using a levering technique. Essentially, we want to end with a half and half view. Half meaning the top half of the video will show you the posterior longitudinal ligament, epidural space, and the traversing nerve root, and the ventral part, the disc, as well as that of the annulus. Caudally, we typically limited by the pedicle, and of course modified by pediculotomy to get into a lower migrating disc. Upper part, the working retractor usually protect the excited nerve roots, as you can see from here. Some case example. This patient has a right L23 paracentric. And then we perform a transforaminal endoscopic lumbardiscectomy. L23, you need to count levels, or put another wire just to make sure it's the correct level. And then dock at the Campbell's triangle. There's the docking point at the more dorsal, as well as that of the lower part of the Campbell's triangle. And you can use an outside-in technique, perform an endoscopic foraminoplasty, endoscopic visualized one. Then we open up this space, and essentially we want to get to the central part of the fragment. So the initial part, when you are taking down this disc may not be the one that actually truly compressing on the nerve root. So limit the amount of discectomy in this area, just to create some space so that you can get into the half and half view. So we do some endoscopic visualized drilling. You can see the foraminoplasty performed by the endoscopic drill. This drill is slim drill with a 3.5 head, and then you can see the visualize the process very clearly. After foraminoplasty, you perform a little bit more discectomy to gain some access space. And then now gradually you can see almost a half and half. You realize that in this outside-in technique there is a little bit more bleeding, so the use of good radio frequency ablator will be good. So now we are removing some disc. To get to the central fragment, you can gradually see that now we are exposing the central fragment. Okay, and then we use a flexible forceps as well as upward pointing forceps to grab the central fragment that is causing the pain paracentral fragment. So now the last bit of the fragment is being grabbed. Bear in mind this L23, so I try not to manipulate the nerve too much. And having a very narrow window, we try not to push it so too deep either. But anyway, we can see that it's a well pulsatile nerve root. And using fluoroscopy, we have checked that we have done sufficient decompression of the disc. And then we can pull out, position cover, and discharge the head out. The next case, also a left L45 TELD, but it's for extraforaminal disc. You can see the extraforaminal region, as well as the foraminal region, there's a prolapse into the vertebral disc. And so we use a more steeper angle. You don't have to go that far away. For L45, a steeper angle, maybe ACM, 6 to ACM is good for extraforaminal disc. You can see when you dock in, you can see the cranial region is on the left, the caudal region is on the right. It's a left-sided approach, and then you can see immediately this if you use extraforaminal approach, you can see the exiting nerve very early in the surgery. Have to be careful with manipulation. You can see that on the 9 o'clock position, exiting nerve is very close by. So now we have removed the extraforaminal disc fragments, and we try to release somewhat the exiting nerve so that it's more easily maneuvered to prevent exiting nerve injury. Despite that, I think we find in some studies that there's a higher tendency for exiting nerve injury in extraforaminal disc, so we have to be really careful. Now we do a foraminoplasty so that we can get to the foraminal region of the disc. Again, I like to do this under endoscopic, direct visualized endoscopic drilling. So how we know whether the medial margin is sufficient? We actually analyze the beginning of the foraminal ligament, and the foraminal ligament is more prominent than you are probably at near the entrance of the foramen. So essentially, as we do the foraminoplasty, you can nearer and nearer, and you can see the more prominent foraminal ligament. And just underneath that would be the traversing nerve root. So this is where we will do the last bit of the foraminal discectomy. Okay, in this case, you can see that we have exposed slightly on the lateral margin of the traversing nerve root, but not the entire traversing nerve root. The whole purpose is not to do a lateral recess decompression, so it's not necessary to expose the traversing nerve root entirely. You can use the same angle and do a lateral recess decompression, and then you will visualize the lateral recess traversing nerve root clearly. You can see the exiting nerve root is in close proximity of this surgery disc. The wound is pretty small. This amount of this is removed, and the patient is very happy and went home very quickly after surgery. So overall, thank you very much for your attention.
Thank you so much. It was a great presentation, and it was very comprehensive as well. My only question is about your measurement and the tangent that you're using to establish how far laterally you have to go. Yeah, of course, all this, if you start reading about this transforaminal technique, you read, especially for the young colleagues, you read initially about this 8 centimeters, 10 centimeters, 12 centimeters, but of course, this will be variable depending on how big is your patient. If a patient is 60 kilos, and if the patient is 120 kilos, obviously, the offset of the midline will be completely different. So it is, my only comment is you try to get a technique that is not blindly applying specific centimeters, but try to adopt a technique that is taking into consideration the specificity of the patient. How big is your patient? How small is it? I personally don't use your tangent technique. I use the supraspinous and suprafacetal line for a rough orientation, and then obviously I will modify. I will be closer to the supraspinous line if my disc is more lateral, and obviously if it's more medial, I will go further down. If you go below the suprafacetal line, it is already becoming dangerous that you will go inside the abdominal cavity and maybe damage organs. What is your comment on that?
I think that is a very good comment. I think most of the workshop that we go for, most of the literature that we read is exactly like what Dr. Nikolai mentioned. We use the lateral view, and then we decide, usually most of the discs are between the line of the spinous process and that of the line of the facet. Usually in that range is pretty safe and you can get most of the disc. And then I have two comments. One is that if we do that, then we tend to take more X-ray, okay, because we have to really get the lateral view point. Of course, that in experience hands just maybe 2 or 3 more shots. Second point is probably my trigonometry is an additional adjunct. It gives you more confidence in the beginning of the operation to actually, I'm let's say 11.5 cm or 13 cm, more exact number off the midline, and I will get to the disc. And true enough, I did in my own series that, it's not published, but I did enough to also using Dr. Peve's technique, and they usually all roads lead to Rome, and just tell you with more confidence that this is the correct region, more from the midline that you can get to the trajectory. So I wouldn't say this is the best way, but it's something quite, you can spend 2 minutes or 3 minutes before the operation looking at MRI, and you get more confidence in the trajectory. Why I spend quite a number of minutes in this talking about docking? I think transforaminal surgery, and Dr. Park show a wonderful biportal surgery. I do biportal surgery myself. Biportal surgery is a floating technique, while transforaminal surgery really needs to be very precise. Of course, that gives a lot of advantage, like awake surgery, local anesthesia surgery. However, we need to really be quite close to the target. We can't be docking to Mars and hope that we can get to Moon, because you will have a higher incidence of inadequate decompression. So we spend time pre-op and best possible to put our endoscope as close possible to the target.
Well, that's great. Yeah, so I completely agree with you. Whatever technique you use, try to use a technique that that is taking into consideration the patient that you're operating. Of course, your technique is very highly sophisticated, and it is very precise, and it's more reassuring. But if you hate mathematics like me, then you can use something else. Yeah. Okay, so let me see if there is any. There is a question here. What is your most common complication doing transforaminal lumbar fusion? That's a question here. That is, do you do transforaminal lumbar fusions and endoscopic? And what is your complication?
I use the posterolateral approach, which I take out the facet joint using a stenosis scope. If I do uniportal, or if I do biportal, I do what Dr. Park shows. I personally don't do transcambin fusion, meaning that I don't just do I don't use a transforaminal scope foraminoplasty and then insert a usually expandable cage. My comment from the literature, which I review and wrote, is that the incidence of exiting nerve root injury are higher in transcambin fusion, and possible subsidence higher in transcambin fusion, meaning we use a transforaminal root with a small scope. I think there are two reasons. One, obviously, as you can see from my the second case, we are pretty close to exiting nerve root once we do a transcambin fusion. If an inadequate foraminoplasty is done, we are really forcing a cage, a typical AP diameter of possibly 7 to 8 mm, and some even put larger, really squeezing into the very, very close to exiting nerve root. If we don't have proper cage glider, then we really have a possibility of crushing the exiting nerve root. So that is one of some criticism of that technique. Of course, in expert hand and adequate foraminoplasty currently, then such technique and expandable cage may decrease the rate of that. And second part about end plate subsidence, which is one of the criticism of endoscopic fusion and mostly get from the transcambin fusion, is that we actually, majority, I think in the majority of people who do transcambin fusion are doing the discectomy or disc preparation under fluoroscopic guidance a lot more than the scope guidance. So they do fluoroscopic guidance, cage preparation, end plate preparation, and then use the scope to double check. So there are possibility of end plate fibrillation. I'm not sure. Of course, in expert hand, again, that can be prevented. And I think Dr. Michael Wang and a number of people have shown very good results. So these are two main criticisms. I think the posterior lateral fusion, which is more quite popular in the world now, especially with the advent of biportal endoscopy, we sec the facet joint and get to very much like what we do in Harm's technique in my tubular fusion. So in that way, of course, in any Harm's technique, then we'll be talking about maybe a bit or more risk in the traversing nerve roots, and then dura injury, dura tear. But having said that, I think in good hands, that is quite low. So overall, I think both are good fusion technique, just steep learning curve, and it will be very interesting to see which one has better results.
Thank you. What is your comment on exiting nerve root dysesthesia? Do you have many of those?
Exiting nerve root dysesthesia is more common in transforaminal surgery when there is foraminal stenosis. So I think personally, I have a few that has usually related to extraforaminal disc. So I typically don't inject steroid or Marcaine in any cases of the patient. Marcaine, of course, for LA, but not for nerve calming the nerve root at the end of surgery. But in exiting nerve root, I mean in the extraforaminal disc, I will do that. I shift a little bit of these cases to revision ones to biportal so that I can do the floating technique instead to prevent exiting nerve root dysesthesia, but that's a separate topic. I think we have to be careful. You can consider using the fully protected tube rather than the bevel tube. That may be one of the ways to do it, but is this more disorienting? But this one thing we have to analyze before op. If the foramen is very tight and there's a very severe stenosis, the traversing exit. If it's a very severe stenosis, the traversing and nerve root will be pushed more medially. You have to be careful in rimming, in terms of preventing traversing nerve root injury. If it's a very tight foraminal stenosis, then we can consider docking onto the SAP, superior articular process, and drill or rim it really directly on the SAP rather than trying to dock into the Cambian triangle into the disc, because that is one of the cause of exiting nerve root dysesthesia in my mind.
That's great comments. And I think probably we will get one more question and then we'll go ahead. Local versus general anesthesia. What do you do?
I think for transforaminal surgery, the purists will do it under local anesthesia with sedation, because then you can eliminate the need for neuro monitoring. The person can the patient will feed back to you if the exiting nerve root is getting tight or the traversing nerve root is getting tight. Of course, for beginners, it's quite unnerving if you take more than 1 hour for 1 or 2 hours on transforaminal surgery. Then the patient get a bit not too comfortable lying in prolonged duration on Wilson frame. But if you get through that, then I think it's actually safer for the patient. In neuro monitoring under GA, whatever the neuro monitor tells you, it will be probably a minute or two later than what you have already done. So I think the real-time feedback is important in the LA sedation transforaminal surgery.
I personally started with local myself, and then now I do everything under general anesthesia. I don't know, maybe I did not get a proper anesthetist that is working better with me, and then the patients were sometimes moving, and then when the patient starts moving, then you will lose the well-centered X-rays, and so this was my main reason to go to general anesthesia. But definitely local has the advantages what you said, but also I found also that I have to, sometimes the patient is not suitable because of being very, very scary about local anesthesia and feeling what's happening there. Although, you know, the sedation will help with that, but still, that is what happens.
I would like to comment on that because I had a recent case. I removed a cement in the L12 region under local anesthesia sedation in an elderly lady. She has no pain after all, but she wrote a complaint letter because she said during the procedure she was anxious, and then when I took out the cement from the traverse near the traversing nerve, there was a period that she feel pain. And if the disc or for this case the cement is very stuck to the nerve, then really no matter how much LA you give, the patient will be uncomfortable. So I can't agree with you more, and that's my probably one of the only complaint I ever get from transforaminal surgery. It's very upsetting because I remove the cement, difficult case, and she has complete relief of symptoms. So yeah, we have to be very careful when we advise patients.
Okay, so thank you so much. It was great discussion, and I think we're gonna move to the next speaker.